the webinar on regional anesthesia. We are always grateful to you. And today's speakers, Dr. E. Senthil Kumar, MD, PDF, and EDRA, postdoctoral fellowship in neuroblocks, and European diploma in regional anesthesia, and junior consultant anesthesiologist in Ganga Medical Center, Coimbatore. And he is giving a lecture on the nerve block, chest, on the chest nerve blocks. The second speaker is Dr. C. Madan Mohan. He is completed MD and a DNB and a PDF postdoctoral fellowship in neuroblocks. He is also from the Ganga Medical Center, Coimbatore. He is talking on the additives in the regional anesthesia. And I take the privilege to introduce the chairpersons today, Dr. Surya Sri, Professor HOD, Siddhartha Medical College and Government Hospital, Vijayawada, and then Dr. T. Venugopal Rao, Superintendent BES Medical College, Kuppam, and also he is the past president ISA Andhra Pradesh and the senior ESA person, and is a great teacher. The third chairperson is the Dr. Chaitanya. He is a practicing anesthesiologist from Rajahmundry, my place. He is enthusiastic and a dynamic anesthesiologist. I request Dr. Senthil Kumar to please start his lecture, please.
Okay.
Or to Dr. Senthil.
Yes, sir.
Thank you.
Very good evening to everyone. Hope everyone are in positive mindset and hale and healthy. Good evening, everyone. Welcome to this ISA Andhra chapter webinar. Yeah, good evening, everyone. Sir, could you see my slides, sir?
Yes. Please continue, Senthil.
Okay. Good evening. I'm going to speak about chest wall blocks. I take this opportunity to thank ISA Andhra Pradesh State Chapter and Dr. Venugopal sir for giving this opportunity. Regards from Ganga Hospital. This is a Ganga anesthesia team. Regards from everyone. Chest wall blocks. Why we need a chest wall blocks? Why you are giving more importance to chest wall blocks of late when compared to epidural and paravertebral? What are the indications? They offer perioperative analgesia to breast surgery, traumatic rib fractures, thoracotomy, video-assisted thoracoscopic surgeries, sternotomy, chest tube placement, and pacemaker incision. In this webinar, I am going to concentrate upon two topics: analgesia to breast surgery and traumatic rib fractures in per se. Why we need chest wall blocks when we have epidural or other mode of anesthesia? They give a better perioperative analgesia with combined multimodal analgesia, reduced pain scores in the first 24 hours post-operative period, reduced opioid consumption, less nausea and vomiting, less sedation when compared to other things, early weaning from ventilator, shorter PACU and hospital stay, less incidence of chronic pain. What are the advantages of chest wall blocks when compared to classical thoracic epidural? It's easy to perform, low risk profile, it's simple and safe, no sympathetic blockade when compared to the epidural, low risk of serious bleeding, performed in both awake and anesthetized patients, real-time visualization with the help of ultrasound. Okay, let's go to the anatomy. What is the anatomy of a chest wall? Chest wall is mainly made up of skin and superficial glands like breast. Breast tissue lies over the chest wall muscles. What are the muscles? They are the pectoralis major, the pectoralis minor, the serratus anterior, and then the rib cage below that. What is the innervation of the chest wall? The innervation mainly from the intercostal nerves from T1 to T12, 10. And also from the supraclavicular nerves that comes from the superficial cervical plexus, and then the muscular branches that comes from the brachial plexus, like medial and lateral pectoral nerve, nerve to latissimus dorsi, and long thoracic nerve. I'm going to explain about a typical intercostal nerve. From T1 to T12, the typical thoracic nerve emerges from the intervertebral foramen and gives off a ventral rami and a dorsal rami. The dorsal rami goes on and supplies the medial back. The ventral rami continues into the paravertebral space and it emerges as intercostal nerve. The intercostal nerve travels between two muscles, the internal intercostal and the innermost intercostal muscle. At the halfway between the vertebra and the sternum, it gives off the lateral cutaneous branch, which penetrates the internal intercostal muscle and the external intercostal muscle, and then gives off the anterior and posterior division, which in turn supplies the sensory innervation of the lateral part of your chest. The same, again, the intercostal nerve continues anteriorly, and then it just comes out lateral to the sternum and gives off medial and lateral branches, which supplies the skin subcutaneous tissue of the structures that are adjacent to the sternum and the medial part of your breast. As such, the per se topic of the today is perioperative breast analgesia. I'm going to concentrate more upon this topic. As because breast cancer, the incidence of breast cancer increases, one of the most common procedures that are performed in and out every day. These are the various procedures that are performed. The simple superficial surgeries like lumpectomy, wide excision, to a more deeper surgeries like modified radical mastectomy. Modified radical mastectomy is the most common procedure that is performed for a CA breast. It involves complete excision of the breast tissue with excision of the superficial fascia of the pectoralis muscle with lymph node dissection, with or without lymph node dissection it involves. Okay, why this chest wall blocks for breast surgery or analgesia to breast surgery is very important, because 50% of the patients have post-mastectomy pain syndrome. Who are the patients who are much more riskier? Young patients less than 40 years and patients who involve axillary lymph node dissections are an increased risk factor for post-mastectomy pain syndrome. What is the post-mastectomy pain syndrome? It is the persistence of pain for more than 3 months. Okay, it seriously impacts the emotional situation, daily activities, and social relationship. It causes a major economic burden to the patient. That's why these chest wall blocks are very important in case of a breast surgery. And I would like all the participants to go through this excellent review article from RAPM. It shows about the perioperative breast analgesia. It gives the insight about the anatomy of the breast, what are the anatomical structures that are interrupted during a surgery, and various modalities of analgesia that can be given to breast surgery. Okay, as such, what is the innervation of the breast and breast tissue? To start with, from superficially from the supraclavicular nerves, and the main cutaneous innervation is from the intercostal nerves, the lateral cutaneous branch and the medial cutaneous branch medially. And it also gets innervated from the muscular branches like lateral pectoral nerve, medial pectoral nerve, nerve to latissimus dorsi, and long thoracic nerve. These are the main innervation of the breast. The main cutaneous and subcutaneous innervation is mainly from the supraclavicular nerves from above, intercostal nerves, the lateral cutaneous branches from T1 to T7, medial cutaneous branches from T1 to T6, and the intercostobrachial nerve, the T2. The anterior division of the lateral cutaneous branch comes via the lateral part of the pectoralis major muscle, and the medial nerves comes over the just adjacent to the sternum. This is the typical cross section at the level of a particular level, T4 level, where the typical intercostal nerve comes out and then it gives out the lateral cutaneous branch. From the anterior cutaneous division supplies the most of the lateral half of the breast and the anterior half of the breast. The same intercostal nerve travels anteriorly and gives out the anterior cutaneous branch. This anterior cutaneous branch gives out the medial sensation to the breast. And what are the muscular branches that are supplying the muscles that are behind the breast tissue? These are derived from the brachial plexus, lateral pectoral nerve from the lateral cord, medial pectoral nerve from the medial cord, long thoracic nerve, and thoracodorsal nerve from the posterior cord. Why these nerves are also important on top of the cutaneous nerves? Why? Because these nerves are very important because they cause the myofascial pain. Because of the stretching, pulling of the muscles underneath during the major surgeries, they cause myofascial pain. This is due to the disruption, stretching, or spasm of the pectoral muscles or the fascia. These nerves are also involved in the post-surgical neuropathic pain. When these nerves gets injured, they have a chronic pain persistent for about 3 to 6 months. This is because of the traction or radiation due to the chemotherapy, radiotherapy, and due to the direct nerve injury during surgery. This can lead to post-surgical neuropathic pain. Okay, this table shows you the difference in the cutaneous innervation and your muscle innervation. The cutaneous innervation is mainly through the intercostal nerves, and the muscle innervation mainly from the brachial plexus, lateral medial pectoral nerve, thoracodorsal nerve, and long thoracic nerve. In case of a superficial surgeries, the main innervation is from the cutaneous and subcutaneous nerves and the intercostal nerves. In case we are doing an extensive surgery like modified radical mastectomy with or without lymph node dissection, That involves your muscular branches from the brachial plexus. Okay. In this slide, I'll show you the various modalities, so that what are the various different modes of chest wall blocks that can be used in breast surgery. Right from thoracic epidural, paravertebral block, erectospinal block, intercostal nerve block, rhomboid subserratus plane block, PEC 1, PEC 2, serratus plane block, pectointercostal plane block, and transverse thoracic muscle plane block. In this webinar, we are going to see about this classical 8 blocks: paravertebral block, erectospinal plane block, PEC 1, PEC 2, serratus, pectointercostal plane block, and transverse thoracic plane block. This shows you the cross section of the typical intercostal nerve and the muscles overlying it, and various points at which we can block the intercostal nerve. Everything to be done under sterile aseptic precautions. The transducer, you can use either high frequency transducer, linear high frequency in case of almost all of the patients, and then low frequency curvilinear probe if the patient is obese or overweight. First thing is the paravertebral block. Paravertebral block is the sine qua non of all the blocks for breast surgeries until about 2014 or 15. After that, it came the all PEC wall, chest wall block, PECs block, and everything. Okay, paravertebral block. Paravertebral space is a wedge leg space, anteriorly bound by the pleura, posteriorly by the costotransverse ligament, and medially by the vertebral body. What are the contents of a paravertebral space? It consists of a thoracic nerve, adipose tissue, and muscle vessels. Okay. How would you do a paravertebral block? Ideally, it can be done under various positions. Patient should be placed in a sitting, lateral, or prone. Ideally, for breast surgery, it is done at the level of T4 or T5. Linear high frequency transducer you used, either you can do it in the parasagittal or transverse mode. The needle, you usually have a 5 or 10 centimeter 22 gauge nerve stimulated needle. Needle entry can be from caudal to cranial or cranial to caudal in case of a parasagittal, or in case of a transverse, it can be from lateral to medial. We usually use either 0.25% bupivacaine or 0.35% ropivacaine. Most of the thing we do in a single shot, about 20 to 30 ml, or you can also put in a catheter and go on for an infusion about 8 to 10 ml per hour. What are the various two important various methods of paramedian approach and the transverse method? In case of a paramedian approach, it's better to have a patient seated and then you be behind, and ergonomically the monitor should be placed in opposite to you. What do you want to see? You always want to see the two transverse process and the paraspinal muscles above and the costotransverse ligament in between the two transverse process. While you are doing a paravertebral or erectospinal block, we need to differentiate between the transverse process and the rib. To start with, we have to scan from the spinous process and the lamina, and then move little laterally. We see the transverse process. It appears as a hyperechoic shadow with hyperechoic line with the shadow beneath that. And if you move still more laterally, you again see an hyperechoic line with the shadow beneath that. How are you going to differentiate between a transverse process and a rib? The transverse process will appear more of a squarish above, and the rib will appear more of a rounded. This is how we are going to differentiate between a transverse process and a rib. You have to move medially and laterally, and then from laterally to medially, and then you have to fix it at transverse process. And this is the typical zone anatomy picture when you scan for the paravertebral space. Right from superficially to the deep, you see the skin, subcutaneous tissue, and 3 paraspinal muscles: trapezius, rhomboids, and erectospinae. Below that, you see a small hyperechoic line with the shadow beneath it. That is the transverse process. You can see the squarish appearance of the transverse process. In between the two transverse process, you see the intercostal muscles. Okay. And then beneath that, you see a small hyperechoic line. This is the superior costotransverse ligament. Beneath that, the hypoechoic space is the paravertebral space. Below that, you see a pleura. Pleura can be identified by the lung sliding line. Okay. And then this is the hypoechoic space, paravertebral space. You just tilt your probe laterally so that the beam goes into the medial and a light oblique orientation. You can easily identify the costotransverse ligament and the paravertebral space. Now you bring in the needle caudal to cranial. As you enter, you'll see the indentation of the costotransverse ligament, and as you pierce the costotransverse ligament, you get a pop off. You have to be very careful because the pleura is underlying it. Okay, and then once the needle is in the correct position, give a test dose of about 3 ml of local anesthesia, and then you see that the costotransverse ligament is lifted up and the pleura moves downwards. This is the end point of a needle insertion, and then you can inject 5 ml aliquots, about 20 to 30 ml. This is about the paravertebral block in paramedian approach. Next is the transverse approach. You place the probe at the select particular spinous level, and then you place it in the transverse orientation. Here, the zona anatomy reveals the skin subcutaneous tissue, the same again paraspinal muscles from superficially, trapezius, rhomboids, and erecta spinae. Here, you see the transverse process medially and the pleura laterally, and the intercostal muscles much more laterally. Here, you have to differentiate between the pleura and the intercostal fascia of the intercostal muscle. Pleura will glistening and lung sliding spine. Just medial to the pleura is the hypoechoic, small, thin hypoechoic space, that is the paravertebral space, and the costotransverse ligament overlaying it. Here you bring in the needle from lateral to medial, and then you pierce the costotransverse ligament and into the paravertebral space. Give a test dose of about 2 to 3 mils, and then after confirming the correct needle placement, you give the whole volume in 5 ml aliquots. Okay, what are the complications of a paravertebral block? It could be a block failure, inadvertent epidural or intrathecal injection, epidural split or hypertension, pneumothorax, intrapleural injection, vascular puncture and bleeding, and local anesthetic toxicity. Okay, next is the erecta spinae block. This is the most evolving blocks of late in the past 2 or 3 years. Many articles, many randomized studies are going on how the erecta spinae is going to help us for breast surgery or any other thoracic surgeries. Here, we place the drug in between the thoracic transverse process and the erecta spinae muscle. We create a plane between the erecta spinae muscle and the transverse process. Here, it's a facial plane block. It seeps from posterior to anteriorly. It can be also done in both paramedian and transverse orientation. What is the technique? This can be done by same as paravertebral in sitting, lateral, or prone. The ideal level is about T4 level, is ideal for a breast surgery. Ideally, a high frequency linear probe will be useful. You can do it in the parasagittal or transverse orientation. At the same 5 or 10 centimeter 22 gauge nerve stimulator needle. Needle in plane from direction caudal to cranial or cranial to caudal or lateral to medial. The same local anesthetic, and volume depends upon the extent of the surgery and what type of surgery. In paramedian approach, we have to place the probe at the desired level, thoracic level, and then we have to try to identify the same transverse process by the squarish arc. Yeah, this is the typical zona anatomy picture where you start from the skin, subcutaneous tissue, and the 3 paraspinal muscles, trapezius, rhomboids, and erecta spinae. Below that, you have to identify the transverse process. You have to differentiate between the transverse process and rib again here also. You have to start from medial to lateral and lateral to medial, and then we have to fix it at the level of the transverse process. Here you have to define the posterior fascia of the erecta spinae. That helps you for easy needle insertion and deposition of the drug. Once you are done with the scout scan, insert your needle in plane from caudal to cranial. The needle tip should just, as soon as you hit the transverse process bone, you have to just aspirate, and then you have to inject the desired volume. You have to make sure that the whole of the erecta spinae is lifted up from your transverse process. In transverse approach, you place the high frequency linear probe in transverse orientation, horizontal orientation. You start scanning from the midline, spinous process, lamina, and then the transverse process. And then you bring in the needle from lateral to medial. Okay, you have to identify the superficial structure, skin, subcutaneous tissue, trapezius, rhomboids, and erecta spinae. And you bring in the needle from lateral to medial. You hit the transverse process, aspirate, and then you inject the volume. Here also, you have to lift the erecta spinae muscle from the transverse process. What are the complications? It could be a block failure. It could be an intramuscular injection. I'll show you a video of intramuscular injection. Pneumothorax, local anesthetic, systemic toxicity, epidural split, and hypotension. This is the video. How could we prevent the intramuscular injection? Hope I don't know, you're able to visualize my video. I bring in the needle from caudal to cranial, and the needle is in contact with the transverse process. You're trying to inject. You can see that there is the splitting of the muscles. It's not the lifting of erecta spinae, it's in the intramuscular injection. Here, what we have to do is that you have to advance the needle further.
Dr. Senthil, can you just play it?
Okay, sure. That is, can you see, ma'am?
We can slide.
Just a minute.
We can see the only the presentation.
Okay, just a minute. I'll again share. Are you able to see now, ma'am?
Yes, yes, yes.
The needle is brought in from caudate to cranial. It's going to hit the transverse process. As it hits the transverse process, after aspiration, we are going to give the test dose about 3 to 5 ml. Now you can see that there is a splitting of the fibers intramuscular. This is a typical intramuscular injection. It's not that the muscle is not lifted up. It's the separation of the muscle fibers. Here what you have to do, you have to push in the needle further. Here you can see the classical separation of the erector spinae muscle from the transverse process below. This is the ideal injection for erector spinae. Again, I'll go back to my presentation. Okay, here we have seen the two blocks, thoracic paravertebral block and the erector spinae block. In both these blocks, excuse me, in both these blocks, we are mainly aimed to block the cutaneous branches, the intercostal nerves, both intercostal brachial and the lateral cutaneous branches from the paravertebral. But we are yet to block the muscular branches. If you are doing a modified radical mastectomy, this part is lacking. We have to block this also. By in MRM surgery, by giving a paravertebral or a erector spinae block is inadequate. We have to block these nerves also from the brachial plexus, muscular branches from the brachial plexus, because they are involved in the stretching and they cause the myofascial pain. How can we block? What are the various modalities to block the brachial plexus nerves from the muscular branches from the brachial plexus? Let's see one by one. The first thing is the PEC1 block. As Rafael Blanco invented in around 2013 or 14, it revolutionized the regional anesthesia for breast surgery. Here in PEC1, it blocks the lateral and medial pectoral nerve. PEC1 block is the placement of local anesthetic in the interfacial plane between the pectoralis major and pectoralis minor. Here, this is the placement of local anesthetic between the pectoralis major and pectoralis minor. Here is the typical anatomical picture where you get the skin subcutaneous tissue, pec major muscle superficially, and the intramuscular plane, and the pec minor beneath that, and the ribs and the intercostal muscles and pleura still more beneath that. Okay, what is the procedure? How we do that? Ideally, you should place the probe just below the clavicle in paramedian sagittal orientation, just medial to the coracoid process. We have to try to identify the ribs. We have to try to identify the ribs and the two major muscles, pec major and pec minor. And then we need a linear high frequency probe, the same 5 cm 22 gauge needle. And the needle direction can be in plane from cranial to caudal, the same bupivacaine. And the dose of the local anesthetic injected is about 10 to 15 mils. Here in PEC1 block, we block lateral pectoral nerve and medial pectoral nerve. This is the typical anatomical picture. Once you place the linear high frequency probe in parasagittal orientation just below the clavicle, medial to the coracoid process, you get this picture. You get the skin subcutaneous tissue, pectoralis major and pectoralis minor, and the ribs, rib 2 and rib 3 adjacent to that, and the pleura, intercostal muscles and pleura beneath that. Here, one thing is that slight medial tilting of the probe will help you to identify the pectoral branch of the thoracoabdominal artery. This helps you to confirm that this is in the ideal plane between the two pectoralis major and pectoralis minor. Next thing is that you bring in the needle in plane from cranial to caudal, and then you needle endpoint of the needle insertion between the intermuscular plane. There is a facial plane that separates between the pectoralis major and pectoralis minor. You give a test dose of about 3 to 5 mils. Once you confirm that the needle placement is correct in the adequate plane, then you can give the whole volume of about 10 to 15 ml. This is the procedure for the PEC1 block. Here you can see the pectoral branch of the thoracoabdominal artery lying in the interfacial plane between the pec major and pec minor, and it is given at the level of rib 2. And in the interfacial plane between major and pec, give about 10 to 15 mils. Here usually blocks lateral pectoral nerve and medial pectoral nerve. Okay, what is PEX2? PEX2 is actually a modification of the PEC1 block. Here, you slide the transducer from the PEC1 position to little more caudally and laterally. Here we just extend our block by blocking our medial and lateral pectoral nerve 2. Blocking in additionally, we block two more nerves: long thoracic nerve, thoracodorsal nerve, and the cutaneous branches of the intercostal nerve, the anterior cutaneous branch of the lateral cutaneous branch, and then the intercostobrachial nerve. This is an extension from the PIC1, and this is called the modified PIC1 or PIC2. Here, the patient is positioned supine. Arm can be slightly abducted 90 degree, or you can do it without abduction. Slide the probe caudally and laterally from PIC1 and identify the rib 3. Here at the level of rib 3, this is the typical zone anatomical picture, rib 3 or rib 4. Here, skin, subcutaneous tissue, the pectoral is major, pectoral is minor, and also you see the starting of the serratus anterior muscle. Here you can see the three muscles, the intercostal muscles and pleura in between the two ribs. Here, PIC2 block involves two blocks. This is the technique where you placed at the level of rib 3 or rib 4 in the anterior axillary line, linear high frequency probe. We need a 5 centimeter 22-gauge needle. A direction of the needle will be in plane from anterior to posterior. Here, PIC2 blocks the lateral medial pectoral nerve, T2 to T6 intercostal nerves, anterior division of the lateral cutaneous branches, long thoracic nerve, thoracodorsal nerve, and intercostobrachial nerve. Once you identify the zone anatomy, then the scouts can insert the needle from anterior to medial. Here, it consists of two injections, one between the pectoralis minor and serratus anterior, and the second between the PIC injection, that is the pectoralis major and pectoralis minor. First injection of about 15 ml of local anesthetic, and second will be about 10 ml of local anesthetic. This is the PIC2 block. This consists of two injections. This picture will show you the more clear picture. The first injection between the pectoralis major and pectoralis minor, and second injection between the pectoralis minor and serratus anterior, so that the whole of the lateral half of the breast is covered with your muscular branches. What is serratus plane block? This is also a modification. It just block the nerves much more laterally. Here we block the nerves predominantly of long thoracic nerve and thoracodorsal nerve, and also intercostal nerves, cutaneous branches of your intercostal nerves. How you do it? You move the probe still more laterally and caudally and fix it at the level of rib 5. It can be supine position with the arm abducted. It could be of a rib 5 at the level of rib 5 in the mid-axillary line with the help of a linear high-frequency probe in transverse orientation with a slight oblique tilt of the probe. Needle direction from anterior to posterior, about 20 mils of local anesthetic. Here we block the T2 to T9 intercostal nerves. It gives a much more extensive coverage of the cutaneous branches of the intercostal nerve on top of lateral long thoracic nerve and thoracodorsal nerve. This is the typical zone anatomical picture when you place the probe at the level of rib 5 in the transverse orientation. You get the skin, subcutaneous tissue, latissimus dorsi muscle superficially, and then serratus anterior muscle much more deeper. And in between the two muscles, sometimes you can see the pulsation of the thoracodorsal artery. This confirms the exact intermuscular plane between the two muscles, and then the pleura beneath that. When you have done the scout scan, bring in the needle from anterior to posterior in plane, and then end point of the needle insertion will be the facial plane between the latissimus dorsi and the serratus anterior muscle. Here you give a test dose of about 3 to 5 ml, and once the needle tip is confirmed, you can give the rest of the 15 to 20 ml. The same serratus plane block can be of two types, either the injection superficial to the serratus anterior muscle or deeper to the serratus anterior muscle. There are the two thoughts are there, either superficial or deep. Why? Because the superficial injection will give a better, much more extensive spread, and it also involves the long thoracic nerve and nerve to latissimus dorsi. But what are the advantage of a deeper injection is that deeper injection spares the long thoracic nerve. Sometimes the surgeons are worried about the intactness of the long thoracic nerve. With the help of a deeper injection, you can spare the long thoracic nerve, and post-operatively, you can confirm by neurological studies or anything. We can just test this immediately whether the long thoracic nerve is intact or not. Okay, this is the purpose of superficial and deeper injection. This slide shows you the two deeper injection between the latissimus dorsi and serratus anterior, and second injection between the serratus anterior. Okay, and again the same table we have been. Here, previously, with the help of an erectospine and paravertebral block, we were blocking the cutaneous innervation. And with the help of a PICS block and serratus block, we are blocking the muscular branches that arises from the brachial plexus. Still, it is not complete because the medial half of the breast, medial breast and the adjacent to the sternum is still spared. What can be done for that? We have two blocks to block the anterior cutaneous branch. From the intercostal, from the midway, from the lateral side of the axilla, the intercostal nerve comes nearby the sternum and it pierces the internal intercostal muscle and gives off the anterior cutaneous branch. It divides into medial and lateral branches. This is the typical lateral and medial branch, just lateral to the sternum. We have two blocks for that. It's called the pecto-intercostal plane block, where we place the high frequency linear transducer just lateral 2 to 3 centimeters lateral to the sternum. The typical sternonatomy picture is that we get the superficial to the deep skin subcutaneous tissue, a pectoralis major, and intercostal muscle, and the pleura beneath it. It is usually performed at the level of rib 3. Usually the rib appears as a rounded structure, hyperechoic line with a shadow beneath it. You have to identify the two ribs and between the intercostal muscles. And then typically it can be performed in the supine position, parasternal at the level of rib 3 or rib 4. We need a high frequency linear probe, the same 22-gauge 5 cm needle. The needle insertion in plane either from cranial to caudal or caudal to cranial. About 15 to 20 mils of the local anesthetic. It blocks the anterior cutaneous branches of the intercostal nerve from T2 to T6. As you've done with the Scouts, you bring in the needle in plane from cranial to caudal. The end point of a needle insertion will be the intermuscular plane between pectoralis major and the intercostal muscle. Once you give the test dose and confirm the adequate placement of your needle tip, you can give the whole volume of about 10 to 15 mils of a local anesthetic. This separates the pectoralis major muscle from the intercostal muscle. This blocks your anterior cutaneous branch. What is the second block? It's also called the transverse thoracic muscle. When you give in between pectoralis major and intercostal muscle, it's called the subpectoral or pectorintercostal muscle block. If you give a little more deeper to that, in between the intercostal muscle and transverse thoracic muscle, it is called the transversus thoracic muscle plane block. The same procedure and technique, everything. Here, this is the typical sonographic picture of the same as the pectorintercostal muscle. Here, you have to identify the transverse thoracic muscle that lies deeper to the intercostal muscle. It's a thin band of hypoechoic muscle that lies between the intercostal muscle and your pleura. By giving this block, you have to be very careful because pleura lies immediately beneath the transverse thoracic muscle. You bring in the needle from cranial to caudal as the pectorintercostal block and place your needle tip between the intercostal muscle and transverse thoracic muscle. Once you are done with it, and then give a test dose of 3 ml and confirm your needle position between the intermuscular plane, between the intercostal and the transverse thoracic, and give the rest of the volume of about 10 to 15 mils. And finally, this is the complete picture. What are the different blocks and everything, cutaneous and muscular innervation, what are the various surgical procedures, and what are the various options that are involved that we have in our hand. From this slide, we can know that no single block is enough for a breast surgery. We need a combination of blocks with multimodal analgesia for breast surgery. For example, if the patient is subject to a modified radical mastectomy, the innervation of the breast tissue is both cutaneous, intercostal nerves, and it also involves the muscular branches from the brachial plexus. If it involves the axillary lymph node dissection, we need the muscular branches of the thoracodorsal nerve and long thoracic nerve. So from this table, we can see that PEX2 is the ideally blocks everything. PEX2 block gives you the wholesome block for the whole breast tissue, for the MRM and everything. But in spite of that, the patients may be complaining because the medial half of the breast is not covered with your PEX2. So if you're going to do a pectointercostal plane block with PEX2, it gives you almost 90% of the analgesia to the breast. So you have to just remember this innervation, what are the various blocks, and then you have to be very careful and you have to plan for what surgery, what block to be given. Okay. Next, we have finished about what are the perioperative breast analgesia. Next, we can go in for our second part of our topic. It's called analgesia for the rib fractures. We come across now every day, now and then, patients come with polytrauma, with multiple rib fractures, and they have difficulty in breathing. They don't breathe, they don't cough, or they have retained secretions. They land up in pneumonia with pleural effusions and everything. We want to put pneumothorax, ICDs. Sometimes they go in for flail chest and respiratory failure. They will be putting into the ventilator. They will be having difficulty in weaning these patients. How these chest wall blocks are going to help for these patients? Let's see. Rib fractures can be anterior, lateral, or posterior. Typical intercostal nerve. This is the main innervation for a chest wall and the rib fractures and everything. We have seen that before. And these are the various modalities or various block techniques that we have with us for blocking the regional anesthesia for rib fractures. How are you going to analgesia? We have thoracic epidural is the long standard, thoracic paravertebral is the gold standard, erector spinae, retrolaminar, midpoint transverse process, rhomboid, septal block. These are the new and emerging blocks for analgesia for rib fracture, intercostal, classical intercostal block, serratus anterior plane block, and subpectoral blocks. What are the advantages of chest wall blocks when compared to the epidural? They give a better analgesia, decreased opioid requirements, improved pulmonary mechanics, early weaning from the ventilator, shorter PSU and hospital stay. Let's see what are the various coverage of the various blocks. What is the extent of coverage of the various blocks? Serratus plane block covers you the almost whole of the lateral half of your chest wall and the anterior, except for the medial portion, which is covered by the anterior cutaneous. And this is the coverage of the erector spinae plane block. It covers almost the whole of your hemithorax, because as it is given more proximally at the back, it covers whole of your hemithorax. And with the erector spinae plane block, it has a communication to the epidural space medially and intercostal space laterally. The coverage extent of the intercostal spread is more, right, from T2 to T10 in case of an erector spinae block when compared to other blocks. It has a much more extensive coverage when compared to other blocks. That's why erector spinae block is much more fascinating. It's coming into the part. Before giving a block to a patient with a rib fracture, there are some certain considerations we have to know that. The choice of the block depends upon the location of the fracture, whether it is anterior, lateral, or posterior. And then factors limiting patient positioning, whether the patient can be sit up, whether he can be sit up, whether it can be turned to the lateral position, or whether it cannot be, the block can be given only the supine position. With that, the block, there are certain constraints of giving the block. Exact point of injection and volume of injected also depends, it decides your spread of the injected everything. And then operator experience, inter-operator variability. If the patient has an anterior rib fracture, we can go and give a erector spinae plane block. In case the patient can be sit up, the patient can sit up, and then we can do the block posteriorly. If the patient is not able to sit up or laterally, if the patient lies only in the supine position, we can go ahead with the serratus anterior plane block or transverse thoracic plane block. In case of a lateral rib fracture, you can go in with paravertebral, erector spinae plane block, or serratus plane block. In case of a posterior rib fractures, the best will be your all posterior blocks, paravertebral block, erector spinae plane block, or retrolaminar block. Okay, in case if the patient has an anterior rib fracture, most medially, or the sternal fracture, in case what are the chest wall blocks that can be given for a sternotomy? These are the two blocks. This can be given bilaterally, pectointercostal plane block or transverse thoracic plane. Bring in the needle, place the needle in between the pectoralis major and intercostal muscle, that is pectointercostal plane block. You go further deeper and you place the needle between the intercostal muscle and transverse thoracic muscle. This is called transverse thoracic plane block. These two blocks can be performed bilaterally, which will give better analgesia for post-sternotomy or sternal fractures. Thank you, sir. Thank you. I hope this talk will be understood and will be taken. Thank you very much, sir. Next, I welcome Dr. Madan Mogan to start his talk on additives in nerve blocks.
Good evening to all the respected senior members of the ISA Andhra chapter and friends. Today I'll be discussing about the additives and adjuvants used in the regional anesthesia. So this topic is going to be more of theory, and whatever points I'm going to discuss now are more based upon the available review literatures, as well as some of them are clinically points which we use in our routine practice. So start with, do we have an ideal drug for regional anesthesia? So, or in other terms, what could be an ideal characteristic of a drug which can be used in regional anesthesia? So, first of all, we take block characteristics. So, for an ideal drug to be used in regional anesthesia, for surgery, it should give an adequate motor blockade, sensory blockade, and analgesia. But for a post-operative or for an acute pain service, we don't want motor blockade, and we just want a sensory blockade and analgesia. So, in for achieving this, we have to cut down the dosage of the local anesthetic. Whenever we reduce the dosage of local anesthetic, the duration of action is going to be reduced. So that is the disadvantage of reducing the dosage of local anesthetic. Second is adverse effects. Again, whenever we want to prolong the duration of action of any local anesthetic, whenever given in any block or in central neuraxial plexus, we are going to have some adverse effect when the dose increases the recommended dosing. So if we take a peripheral nerve block, whenever the dose of local anesthetic is going to be more, we have local anesthetic systemic toxicity. So again, whenever we establish a central neuraxial blockade, especially in the thoracic and the lumbar region, there's going to be autonomic blockade, which will lead to hypotension, bradycardia, and hemodynamic instability. So for reducing this, what we can do, we can go for either continuous blockade by making use of placing catheter in the plexus or in the central neuraxis and continuous infusion. Again, by using this catheter techniques, again, you can have primary failure where we are not able to place the catheter at the appropriate site, or it may be a secondary failure due to migration of the catheter from the site where it's supposed to be there. Or it may, second thing is, the catheter itself can have some problems, like it may get knotted, it may get blocked due to adhesion by the soft tissues around the site where it has been inserted. And cost is again one issue, and somebody has to monitor the patient whom the continuous regional anesthesia is going on. And even in those cases, when there is catheter migration, we can have a motor blockade whenever in the central neuraxial is used, or if it migrates to intravascular region, then last is a chance. Third is availability. So in order to come out of in order to overcome these disadvantages, new vehicle like liposome cyclodextrins are being studied, and these have been started using for regional anesthesia. But the disadvantage is the availability and cost. If we take a liposomal bupivacaine, it is almost 200 times the cost of a racemic bupivacaine. And even for advocated procedures, it is only advised for skin infiltration, tab block, and interscalene plane block so far. So in order to overcome all these problems, we can make use of some other drugs which is of other class, not a local anesthetic, which is deposited perineurally or in sometimes given in other forms. That way we can decrease the onset of action as well as improve the quality of block and increase the analgesic duration. And also by doing this, we can cut down the maximum local anesthetic doses and associated problems either in a peripheral nerve block like LAST or in a central neuraxial blockade, mainly the hemodynamic instability due to autonomic blockade. So what is the rationale behind use of adjuvants? So any drug to be used as adjuvant in local anesthesia in clinical practice should have at least meta-analysis data proving that it has some beneficial effect whenever used in regional anesthesia, and there should be a appropriate mechanism of action for each and every adjuvant used in the regional anesthesia. Second and third is side effect profile. If we take, it should be tolerable and it should be not giving any its own adverse effects compared to local anesthesia per se. And availability. And fourth thing is, whatever the adjuvants used perineurally, it should be of preservative free, and especially when we are going to the central neuraxial blockades, the adjuvant should be of without any preservative, because the preservative itself may cause some neurotoxicity. And last, some of the newer drugs are being started for as an adjuvant, are being studied as an adjuvant without much any human studies to support them. In those cases, we can accept them as an adjuvant whenever there is a safety issue which doesn't show much toxicity to the nerves and other complications done in animal studies. So before going into the each and every drug, we'll go through the gate control theory. Why we want to know about the gate control theory? So in 1965, Melzack and Bock proposed that pain, whenever happens, it gets modulated or gated at various points, starting from the primary neuron to central postcentral cortex, where the pain is perceived. So it can get gated at various levels depending upon the site of action. And also, so many neurotransmitters are being released at the site of injury or at the primary neuron or the dorsal arm of the spinal cord or even in the supraspinal sites are responsible for the transmission of this nociception from the periphery to the center. So use of agonist at the inhibitory receptors and antagonist at the excitatory receptors allow a multimodal approach with optimization of pain control and reduction of adverse effects. So the concept of multimodal perineural anesthesia is being evolved, where not only local anesthetic is being put over the nerves, also some other drugs are being used to provide the multimodal analgesia in the peripheral blocks as well as the central neuraxial blockades. So if we take the gate control theory, whenever there is a pain stimulus, the primary neurons, that is the A delta and C fibers, carries the pain stimulus right from the periphery to the dorsal horn of spinal cord, where the second order neurons perceive them, and the spinothalamic tract will ascend to the thalamus, and the tertiary neuron through the internal capsule will reach the postcentral gyrus, that is the central sensory cortex. There, pain is perceived, and further there is a modulation of pain by the descending inhibitory tract. This is the normal pathway. So most of the local adjuvants being used in regional anesthesia will have their action in the dorsal horn of spinal cord, mainly in the rexed lamina 2, that is the substantia gelatinosa. So what are the adjuvants which have been used in the past and present? It can be broadly classified into opioids and non-opioids. Opioids, if we take, we have fentanyl, morphine, tramadol, buprenorphine, nalbuphine. Out of this, fentanyl, morphine, and tramadol, buprenorphine are being used widely in our country. Out of India, other drugs like diamorphine, oxycodone, and some other similar drugs of oxycodone are being used for as adjuvants in regional anesthesia. Whereas the non-opiates adjuvants includes vasoconstrictors like adrenaline and phenylephrine, and alpha-2 agonists like clonidine and dexmedetomidine, corticosteroids like dexamethasone, NMDA receptor antagonists like magnesium, ketamine, and GABA drugs like midazolam, and parasympatholytics like neostigmine, and even soda bicarbonate. So this is one of beautiful article where all the available studies in the prior to 2015 have been analyzed for use of any drugs as an adjuvant in regional anesthesia. They have gone through almost 12,900 articles. Out of them, 61 high quality studies have been taken, and they have come up with the idea of what are the adequate dose of each adjuvant, how they have to be used, and what are the hypothesized as well as proven mechanism of action and all. And as every one of us know, none of the drug is FDA approval, and all of the drugs being used are off-label only, except adrenaline. And the concern for side effects and potential toxicity is always there. So we have to be more vigilant whenever we use adjuvants in regional anesthesia. So we'll start with opioids. So if we take opioids, and we have three major opioid receptors: mu receptors, gamma, mu, kappa, and delta. Out of this, mu receptor are more important for analgesia. If we take a normal person, the mu receptors are mainly situated in the CNS and the spinal cord, especially in the lamina 2. But if we take peripheral nerves, there is no mu receptor for a normal person. The mu receptors are only transferred from the spinal cord to the site of inflammation, usually around after 72 to 96 hours. This breakthrough study has been given by Christopher Stein, and this is the idea behind using opioids in the peripheral nerve blocks for patients who have inflammation for a long time, for chronic patients like patient who are coming with diabetic neuropathy or patient who are coming for repeated surgery post trauma. So in those patients, we can use opioids periphery also. But for other persons in whom there is no availability of mu receptors in the periphery, we can make use of opioids in the central neuraxis where it acts in the spinal cord, especially in the dorsal horn, as well as from there it goes to the CNS and acts in the CNS sites where the mu receptors are present. So if we take the mechanism of action, the mu and the opioids given in the intrathecal region or in the epidural region will reach the spinal cord where it causes the blockade of calcium channels. So calcium channels, once it's blocked, there will not be any release of neurotransmitters like glutamate and substance P. Thereby, it blocks the transmission of signals from the primary neuron to the second order neurons, as well as it also acts in the postsynaptic, that is the secondary neurons, by causing the increase in influx of potassium, thereby causing hyperpolarization, and further stimulus will not reach the brain centers. So these two are the main important action of opioids in the spinal cord, other than the CNS action, which is equal to what we use in IV. So if we put any opioid drug intrathecally, it directly goes to the dorsal horn of spine, and it has, that's the major effect, like what we saw in the previous slide. And out of this, some of the opioids will remain in the CSF for a longer time, depending upon their lipophilic property. So if they remain in the CSF for a longer time, they will gradually go cephalate and enters the CNS centers, thereby causing analgesia, just similar to the drug which have been given IV. One more mechanism is the drug can, if the drug is more lipophilic, the diffusion of the drug from CSF to the epidural space and thereby entry into the systemic vascular region by the absorption from the veins also possible, but this effect is minor whenever the drug is placed intrathecally. And whenever we put opioids epidurally, the major effect will be direct absorption from the venous plexus of the epidural, and the minor effect or the drugs which remains in the, which travels the dura faster, like more lipophilic drugs, they will enter the CSF and act in the dorsal horn, especially in the substantia gelatinosa. So lipid solubility is a more important character of the opioid to describe its mechanism of action. So if we take a highly lipid lipophilic drug like fentanyl, there will be a rapid onset because it goes and targets the dorsal horn of spinal cord, and the duration is shorter because the systemic entry of the drug will be more, so more metabolism and availability of drug in the spinal cord will be less. So the respiratory depression causing by these drugs are relatively less compared to a low lipophilic drug, where the onset will be very slow because it will take more time for the drug to reach the dorsal horn, and so the drug also will remain in the CSF for a longer time, and it causes the spread of drug to the cranial centers. So once the drug reaches the higher centers, there is chances of delayed respiratory depression, which usually we observe in epidural morphine or even intrathecal morphine. So the advised doses for some of the commonly used opioids are fentanyl intrathecal 10 to 25 mg is advised, whereas epidural dose is 50 to 100 mg. Whenever we plan to give epidural infusion, 2 microgram per cc of local anesthetic is advisable. And for morphine, intrathecal as low as 50 mg to maximum of 300, even up to 500 mg, we can give intrathecally. And for epidural, the dose usually remains around 2 to 5 mg, not more than 6 mg. And whenever we give morphine, either intrathecal or epidural, we have to watch the patient for postoperative respiratory depression. So if we take the benefits of morphine given perineurally, if the what are the previous studies tells is the side effects like nausea, vomiting, pruritus, and somnolence are more compared to an IV or IM use. So better we can switch over to some other mode of adjuvant or even catheter and continuous infusion with the local anesthetic. But if we take fentanyl, the prolongation of motor blockade is of not much significant. Hardly it's about 1 to 1.5 hours. But if we take the side effect profile, the compared to morphine, it's better, but the chances of pruritus is almost comparable. Only advantage of fentanyl being used as an epidural or intrathecal adjuvant is the respiratory depression is much lesser compared to morphine. So one other drug is tramadol, though it is a weak opioid, but it's been extensively used mainly in the intrathecal epidural as well as sometimes in the intrathecal also. So intrathecal, usually the dose is almost 50 mg, and for epidural 100 mg. And if you take the benefit of tramadol as an adjuvant, it is not going to give much analgesia as compared to the morphine and fentanyl, and also there will be chances of neurotoxicity whenever the drug dose reaches more than 100 mics intrathecally. So buprenorphine is yet another opioid drug. It's a mixed opioid drug. It has agonist activity in mu as well as antagonist activity in kappa and delta receptors, and it is being used mainly in the central neuraxial blockade as an adjuvant. The only disadvantage of buprenorphine is it's 5 times more potent, 5 times more prone to have post-operative nausea, vomiting when compared to other opioids. And the advantage of using buprenorphine in intrathecal or epidural as an adjuvant is it increases the local anesthetic duration of action by almost 1.5 to 3 times. But whenever we use buprenorphine as an adjuvant, especially in the central neuraxial blockade, we have to put the patient on multimodal antiemetic, not only with a single class of drug. Better to add 2 or even 3, and if at all we are going to use. And the recommended dose of buprenorphine is 150 to 300 mics in intrathecal, and epidural it's 3 mics per kg. Next, we'll come to vasoconstrictors. Epinephrine, phenylephrine is not much used as an adjuvant in the regional anesthesia. Epinephrine we are mainly using in combination with lignocaine, adrenaline. And what is the mechanism of action is it has 2 actions. One is by increasing the availability of local anesthetic in the site of injection by causing vasoconstriction locally, thereby increasing the duration of action, not to much extent, but slightly. Second is it itself has its own nociceptive action, mainly by acting in the alpha-2 adrenoceptors in the substantial derivatives of the dorsal horn. So the advantage of adrenaline using as an adjuvant is one way is it can be used as a marker. So whenever the drug injected perineurally, if it enters system, we can able to identify the tachycardia, which shows that some of our drug has entered the system. We have to be more cautious for a possible blast, as well as it also restricts the it also causes the vasoconstriction locally, thereby increasing the availability of the drug injected in the peripheral region. So if we take adrenaline as an adjuvant, it is mainly used with lignocaine because the profile of pKa and using adrenaline is more matching with lignocaine. Whereas if we take bupivacaine, ropivacaine, it doesn't match more. So the duration of action extended for bupivacaine or ropivacaine is not of much importance compared to a lignocaine. So the dose advisable is 2.5 to 5 mics per ml with local anesthetic. And for a central neuraxial blockade, especially in intrathecal, previously it has been thought that whenever we put adrenaline intrathecally, it may cause vasoconstriction and reduction of blood supply to the spinal cord. But the recent studies have shown there is not such occurring. But again, the benefit of using intrathecal adrenaline is of not much use. So it's not advisable to put adrenaline as an adjuvant in the intrathecal spike. Again, one more thing we have to keep in mind is whenever we establish a block using adrenaline as an adjuvant, especially in the peripheral nerve blocks. Patient like those who are hypertensive and diabetic neuropathy, especially diabetic patient with autonomic neuropathy, it's better to avoid adrenaline as an adjuvant because it may lead to reduction of the blood supply to the nerve, thereby causing nerve ischemia and further nerve damage. So coming to alpha 2 agonist. So alpha 2 adreno agonists inhibit pain transmission by binding to pre as well as post synaptic alpha 2 receptors. So alpha 2 receptors are present in the primary neuron as well as the secondary neuron, and mainly the action is happening in the substantia gelatinous of the dorsal and spinal cord. So the receptors also exist in brain, mainly the locus coeruleus, where these drugs, whenever injected IV, will produce sedation as well as analgesia through the central mechanism. And the cardiovascular depression, mainly the bradycardia and hypotension, occurs when the drug is given either central neuraxially as well as IV during the local anesthesia establishment. So we'll see clonidine. Clonidine is alpha agonist. Its selectivity is not as good as dexmedetomidine, and it is mainly having hypotensive, sedative, and analgesic property. Clonidine has been administered orally, intravenously, and transdermally as an adjuvant for postoperative pain relief, but it is mainly administered via intrathecal or epidural route as an adjuvant to opioids and local anesthetics. So if we take clonidine as an adjuvant, it's mainly advisable to give the drug either intrathecally or epidurally rather than going for a peripheral nerve block, because the availability of alpha 2 receptors present in the peripheral nerves are nil, and it may cause alpha mediated vasoconstriction in the periphery, thereby slightly increasing the duration of action. So it is of not much use whenever the drug is being used in the peripheral nerve block, but obviously it has better profile whenever it's used in the central neuraxial blockade. So how does it work? So if you put intrathecal clonidine, there will be increase in the acetylcholine release by the clonidine acting the alpha 2 receptors, which will lead to stimulation of muscarinic receptors, which in turn leads to increase in the GABA. So GABA causes inhibition of the excitatory neurotransmitter, that is glutamate, thereby preventing the transmission of painful stimulus from the primary to the secondary neurons, as well as it also causes the descending inhibitory response to go off. So what are the action of clonidine in periphery? Peripherally, if you put, it has local anesthetic properties, but the dose for providing local anesthetic property of clonidine is very much high, in that it will cause severe adverse effects like bradycardia and hypotension. So we are not able to use clonidine as an local anesthetic whenever we are giving in a peripheral nerve block. And again, vasoconstrictor effect like blocking of alpha 1 receptors, causing the increase in availability of local anesthetic in the periphery, like what adrenaline does. But again, this effect or this mechanism is not going to prolong your duration of action of local anesthesia. So coming to the systemic review of clonidine as an adjuvant. So epidurally, if you want to give clonidine, the bolus dose is usually around 75 to 150 microgram. But for pediatric or for a patient who are of lower weight, we can go for a 1 to 1.5 mics per kg. And it causes prolongation of the sensory as well as motor blockade. So if and the problem of giving epidural higher doses, patient will develop hypotension and bradycardia, and it hampers, like what I told in the previous slide. Sole anesthetic, if you want to use clonidine as a sole anesthetic, is not possible because the dosage recommended will not have a local anesthetic like property. Coming to the intrathecal dose, the usual dose is 20 to 50 mics, and it prolongs the duration of sensory as well as motor blockade. And the usual timing of prolongation is almost 1 to 2 hours for motor blockade, and for analgesia, it's almost 1.5 to 2 hours. And intrathecal clonidine, which more higher, like the higher doses, 30 mics or 40 mics or even 50 mics, the chances of bradycardia and hypotension are more. So in our hospital, we are making use of clonidine intrathecally mainly for hip arthroplasty cases where we want an hypotensive field. So we are making use of for that purpose only. But epidurally, we can go with some other drugs for prolongation of the local anesthetic action. So for a protein use as an adjuvant peripherally and the caudal block, the recommended dose is 1 mg per kg. It causes doubling of the duration of local anesthetic action, and it also provides a sedative action because the drug absorption into the system in a pediatric caudal space is more. So it has both central as well as the spinal mediated action. For peripheral nerve block, as I said, it's not going to give much prolongation of our local anesthetic action, and whatever the prolongation expected is of par with adrenaline only, and the maximum recommended dose is 150 mics in any peripheral nerve block. And second alpha 2 agonist is a dexmedetomidine. This is 7 times more alpha 2 selective, and the mechanism of action is similar to that of clonidine. And the dose of dexmedetomidine for peripheral nerve block is advised as 1 mg per kg, and for intrathecal it's around 5 to 10 mg, though not much studies are being published regarding the intrathecal dosage and the expected duration and side effect profile. And if we take the adverse effects of dexmedetomidine either intrathecally or epidurally, again like clonidine is going to cause irreversible bradycardia and hypotension. And taking to toxicity profile, it may not cause much neurotoxic like few other drugs like midazolam and neostigmine does. So there is a increase of duration of action, and in intrathecal as well as epidural, like epidural procedures, time is almost 200 to 300 minutes. And it is preferable not to use in this drug as an adjuvant in patients who are not hemodynamically stable. Coming to corticosteroid, the main drug used as main steroid drug used as an adjuvant even in our hospital is dexamethasone. The mechanism of action of dexamethasone is it reduces the neuronal discharge, and it has anti-inflammatory action, and it decreases the nociceptive C fibers activity through a direct effect, and thereby inhibition of the potassium channels. So if you take literature, the duration of action of peripheral nerve blockade whenever the dexamethasone is used as adjuvant, the time of increase is almost 233. This is a average score of 12 articles being published in that review. And for a long, this is for a long acting, and for a short acting, it's almost 300 minutes. And if we take difference between the dosage of dexamethasone, the commonly advised dose is 4 mg, and maximum up to 8 mg we can go. 4 mg dose and 8 mg dose, the duration of prolongation is not much difference. It's hardly about 1 to 2 hours. So it's better to go for a lower dose, that is 4 mg per block, or otherwise 0.1 mg per kg we can use for the peripheral nerve blockade. And again, it has its own antiemetic effect, so chances of PO and V is less. One more thing is whether the IV dexamethasone given will have some effect on the peripheral nerve blockade. Yes, there are studies which shows that in comparing IV dexamethasone and perineural dexamethasone, the duration of prolongation is similar, but there is some reduction in the prolongation of action in IV, but it's of similar values only. And second concern is rise in blood sugar. So whenever we put dexamethasone in as an adjuvant, there will be a rise in the blood sugar. If we take 4 mg dexamethasone given in a block, there will be rise of 1.5 millimoles, that is almost 30 to 40 mg per deciliter of blood sugar increase. But for a 8 mg drug, the increase in blood sugar at 1 hour will be around 60 to 70, which makes some significance. So in patients who have uncontrolled sugar, and those patients, we have to reduce the dosage of dexamethasone. In magnesium, magnesium and ketamine both are NMDA receptor antagonist, and if you take magnesium, it causes antagonism of NMDA receptors, causing attenuation of central sensitization as well as inflammation excuse me, because of inhibition of dorsal horn of NMDA receptors, and it also causes inhibition of calcium channel influx in the presynaptic site in the primary neuron. The advised dose is a loading dose of 30 to 50 mg, followed by a maintenance dose. Whenever the dose magnesium is used as an IV for as an adjuvant, but whenever the magnesium is used as an intrathecal adjuvant, the dose recommended is 50 to 100 mg, and for epidural, usually it's around 300 to 400 mg, and not more than 500 mg. So this is the NMDA receptor present in the substantia gelatinosa. So it causes one of the mechanism is by blocking the calcium channel in the presynaptic membrane. Second one is the NMDA. Again, both the drugs are non-competitive blocker of the NMDA site, thereby preventing the stimulus from passing from primary to the second order neurons. Again, ketamine, if you take, action is similar to the magnesium as far as NMDA receptor is concerned, and mainly the advantage of ketamine usage in the perioperative period is it prevents the formation of chronic pain, mainly by preventing the central sensitization. And nociceptive stimuli causes glutamate release from the excitatory synapse. This in turn activates the NMDA receptors in the central and peripheral nervous system, resulting in the voltage gated sodium as well as calcium channels into the cell and potassium out of the cell, like what we saw in the magnesium. So at present, the advice of ketamine as an adjuvant is intrathecally, if you use, we have to use ketamine or preservative-free ketamine, because the racemic mixture, whenever used with the preservative, can lead to apoptosis of the nerves. So it's not advisable. And if at all we are going to use intrathecal ketamine, the dose should be less than 0.5 mg per kg. And whenever we are going to use it epidurally, the dose is 0.5 to 1 mg per kg. So the review article of 2015 shows its efficacy is not that great for especially for a adult patient, and it's preferred not to use this. And if at all we want to use, make use of ketamine or the preservative-free ketamine. So midazolam as an adjuvant. Midazolam is a GABA receptor agonist, where the benzodiazepines attaches to the GABA A, thereby activating the chloride channels, and further it will lead to the blockade of the neurotransmitters, mainly the glutamates. And the action is like other previously seen adjuvants, it acts in the substantia gelatinosa as well as in the descending inhibitory pathway. So intrathecal recommended dose is 20 mg per kg, and maximum dose we can reach up to is 2.5 mg. And if you take published literature, high quality literature, the studies are very limited only, and we are more worried about neurotoxicity, though it is a short-term neurotoxicity, but the chances of transient neurological symptoms are there with whenever we use midazolam in intrathecal region. If you take epidural, the recommended dose is 10 to 20 mg per kg per hour as an infusion, and not more than 12 hours is advised, again for the neurotoxic concerns. And neostigmine is a drug which increases the availability of acetylcholine in the synaptic cleft in the substantia gelatinosa. So once the acetylcholine levels are more, it goes and bind to the muscarinic as well as nicotinic receptors in the dorsal horn of spinal cord, and the analgesia will be provided by blocking the neurotransmitters, and there will not be any motor or sympathetic blockade. Again, the main concern of using neostigmine as an adjuvant, especially in the central and axial blockade, is it is more prone for nausea and vomiting. So it's preferred not to use neostigmine as an adjuvant, especially in the central neuraxial blockade. And for peripheral neuraxial blockade, there are not much studies using neostigmine, and there is no receptor for periphery in the periphery for the neostigmine to act and cause some analgesia. So if at all we want to use, the recommended dose is epidurally, we have to give a single dose of 50 to 100 mg. And in labor analgesia, the dosage is more recommended. It's almost 300 to 500 mg. So sodium bicarbonate. Sodium bicarbonate is used as an adjuvant for local anesthesia, mainly for the purpose of decreasing the onset of action. How? Because the pKa is the criteria depending upon the which action of local anesthesia is going to happen. So if more unionized local anesthetic molecules are available perinaturally, there will be a faster action of the local anesthetic. So we have to bring the tissue pH closer to the pKa, and more of the available local anesthetics are having a pH of around 3.5 to 5.5 because to increase the shelf life of the drug. So we are adding a drug which increases the pH, that is the alkalinization of the local anesthetic, thereby increasing the tissue pHa. So the more unionized drug will be available perinaturally, causing earlier onset of the blockade. And at present, the reviews shows that it can be used either in the epidural or for a skin infiltration. Again, epidural may be for decreasing the onset of action and not recommended for peripheral nerve blockade or the intrathecal usage. And skin infiltration, mainly sodium bicarbonate, whenever added with local anesthetic for skin infiltration, it prevents the stinging pain happening during the skin infiltration. And the recommended dose is 2 ml whenever lignocaine is used, and the available concentration should be 8 pounds per person. Whenever you are using 7.5%, we have to go for 2.5 ml or maximum to 3 ml. But for a long acting like bupivacaine or levobupivacaine, 0.1 ml is sufficient enough to use the increase the pH. But for ropivacaine, it is not accepted method of using as an adjuvant, because if we make use of sodium bicarbonate mixture with ropivacaine, the chances of precipitation of the drug is more, and usually after 10 to 15 minutes. So better not to use, or if at all you want to use, the drug has to be mixed just prior to the injection of the drug. So this is yet another compilation of all the drugs, and the most commonly used are adrenaline, codeine, dexmedetomidine, dexamethasone, and buprenorphine. If we take these adrenaline, whether given epidurally or peripheral nerve blockade, it's going to increase by 1 hour only. And the usual recommended dose is 2.5 to 5 mg. If you take clonidine, intrathecal as well as epidural, it's going to increase the duration of action of local anesthetic by 2 hours. And the recommended dose for epidural is 150 mg, and as well as for peripheral. And for intrathecal, it's 20 to 50 mg. For dexmedetomidine, yes, it's going to prolong the duration of action of local anesthetic whenever it is given epidurally or in the peripheral nerve block. And the duration of action is almost 6 hours. And the recommended dose is 5 to 10 mg for intrathecal, and for peripheral nerve block, 50 to 60 mg. Same for the epidural. So take dexamethasone, it definitely increases the duration of action, and it usually increases up to 8 hours. And our own hospital, we usually see around 10 to 12 hours of prolongation of action of the local anesthetic. And optimal dose is 4 mg. And if you don't have any contraindication, especially in diabetic patient, we can go up to 8 mg. For pediatric patient, I'll be discussing in subsequent slides. And buprenorphine, again, intrathecal as well as epidural is recommended. The maximum prolongation is expected in this, and the duration is almost 9 to 10 hours. Only analgesia, not the motor or sensory blockade. And the optimal dose for intrathecal is 100 to 300 mg. Now coming to the additives usage in pediatric regional anesthesia. The problem in pediatric regional anesthesia is the local anesthetics have limited duration of action because of more systemic absorption, and the availability of drug present in the site of action is less. So in order to overcome this, we have to do some techniques. Either it's a continuous epidural, continuous catheter technique, or making use of some adjuvants. So advantage of using adjuvant in pediatric regional anesthesia is it's going to prolong the block duration as well as analgesic effect. And again, pediatric regional anesthesia, especially in the smaller child, we are going to make use of any type of consciousness, either maybe a IV sedation or a TIVA or even general anesthesia. So whenever we are making use of additives in regional anesthesia, we can reduce the requirement, and thereby it can lead to smooth emergence, and we'll get a very good post-operative recovery. So this is the evidence-based conclusion and clinical advice for neuraxial adjuvants in pediatric patient from the advisory committee of ASRA. So clonidine, whenever used in uracil, it should be of 1 to 2 mg per kg, and morphine is 10 to 30 mg per kg. And the prolongation of duration of spinal blockade is significant in these cases. And if at all we want to use ketamine, and it is 0.5 mg per kg, again we are going to use preservative free only. Yes, ketamine is available, that is preferred, and we have to avoid in neonates because of the apoptotic problems. And synthetic opiates, if we take fentanyl and sufentanil, there is currently lack of evidence that synthetic opiates produce any relevant effect when they are used as an adjuvant in the central neuraxial blockades or in the caudal blockades. And corticosteroids, dexamethasone, mainly it's not recommended for central neuraxial blockade, but for peripheral nerve blockade we are using, and even the advisory has given a green signal for this. And the recommended dose is 0.1 mg per kg. And for peripheral nerve blockade, if we take dexmedetomidine has been advised, and the dosage advised is 0.3 to 1 mg per kg. And the expected duration of action or even the prolongation of local anesthetics usually around 4 to 6 hours. So some other drugs are being under research, mainly the adenosine calcium channel blockers like verapamil, NSAID, even ketorolac. Ketorolac has been given as infiltration as well as intra-articular injections for as an adjuvant for local anesthetic, and calcitonin and so many other drugs are under research, but not we are not at present, we are not having high quality publications telling that the adjuvant has some effect over the other drugs. So thank you.
Thank you, Dantil Kumar sir and Madan Mohan sir for the excellent presentation.
Thank you, sir.
Dr. Suryasri sir and Dr. Venugopal.
Thank you.
Chaitanya sir, please have any questions?
Yeah, good evening to all. This is Dr. Venugopal Rao
Good evening, sir.
from PES Institute of Medical Sciences, Kupam. So, Dr. Madan, this
Yes, sir.
presentation it elaborately covers the adjuvants used in local anesthetic agents. Dr. Srinivasa Rao has put a question: which is the best agent adjuvant for local anesthesia for prolonged duration among the described ones?
Sir, if we take for peripheral nerve block, either it's a plexus block or a single peripheral nerve block, dexamethasone will be a preferred drug. And in our hospital, we are using that only, mainly for it doesn't have side effects compared to opioids as well as other drugs, and it has the maximum duration of prolongation, as well as it has anti-emetic property also, and availability is and more importantly, it's cheap.
Yeah.
Regarding dexamethasone, we use
Yes,
it
sir.
for brachiplex block one
Yes,
case. In case of prolongation up to 24 hours, the
Yes, sir.
patient
Yes, sir.
is unable to move the limb. We are afraid of that it is due to the dexamethasone or some nerve injury is there.
Whenever we use long acting like levobupropion and ropivacaine, which we commonly use here, and we use dexamethasone 4 mg for brachial plexus, patient
Yes,
will have 18 hours of motor blockade and
Yes,
analgesia for 24 to 28 hours. Sir.
that is the more worrisome for surgeon also, no, sir. Because he is
So
very.
whenever we establish the block, at that time itself, we'll reassure the patient that we are going to have a prolonged action and no need to get worried. Even if the patient is not able to move the limb for more than 24 hours.
Yeah,
But
I
of
would
course,
like,
after
I would
24
like
hours,
to add, Madan, Dr. Madan, I would like to add,
yes, sir.
if you use fentanyl, bupropion, and epinephrine,
Yes, sir.
it has been observed 18 hours of paravertebral block is observed.
Yes, sir.
18 hours of sensory blockade was observed.
Mhm.
And I shared 2 reference articles in the group.
Okay, sir.
So these are the 2 review articles are there
Okay, sir.
on adjuvants and future trends.
Yes, sir.
So members, if they're interested, they can go through that
Sure,
articles.
Yes, sir.
Thank you for your presentation, and
Thank you.
I thank ISCS State branch for giving me the opportunity to chair the session. I'll hand over to Dr. Suryasri.
Good evening, sir.
Good evening, Amma.
Thank you, sir. Thank you for joining the meet, sir. I'm also thankful to ISA and AP for giving me this opportunity. It was nice to hear to topic of interest for all, not only specialist anesthesiologists, even we are who are practicing in government hospitals. About adjunct and about techniques, it's really interesting. Thank you, Dr. Sahil and Dr. Karan.
Thank you, ma'am.
Dr. P. Chaitanya is on the board. No.
Hello. Hello. Yes, sir.
Sir, please, sir. You are
I
on
should,
person. Please share your
yeah.
experience.
Thank you, Dr. Sendil and Dr. Madan Kumar. It's been, and also team of Ganga Hospital. It's been very nice presentation, very thought-provoking, and new aspects of blocks have been learned by us. And hope these, ultrasound comes into play in all the peripheral setups also. So we could have more access to these kind of blocks and give better quality of analgesia to patients required. I thank ISA State for giving me an opportunity to chair this session, and I thank our chairpersons, my Professor Suryasri Madam and Professor Venugopal Rao Garu, and thank you, Srinath sir.
Thank you, Chaitanya.
Thank you, Chaitanya, sir. It is the right time to, sir, please, sir.
One question from the members, sir. So what they have asked, can we add more than one additives? Yes, we can add more than one additives. That is there.
That is the evolving concept of multimodal perineural anesthesia.
Peripheral anesthesia.
Where more than one adjuvant is being added. Even in our hospital, some of the cases where we want to have a prolonged action, especially in the intrathecal block, we make use of clonidine as well as fentanyl along with local anesthetic, and we almost observe some 4 to 5 hours of motor blockade itself, mainly for patients in whom epidural is not possible or epidural is not affordable. So we make use of that. And even for peripheral nerve blockade, we generally prefer a single adjuvant only, but there are studies where 1 or 2 extra adjuvants have been used in peripheral nerve block. So,
Dr. Madan, can you add on the charged molecules? The future trend is charged molecules for prolongation of the blocks.
So liposomal bupivacaine mainly coming as upcoming as a drug for prolonged action in the peripheral nerve block, sir.
Yeah.
And if we take, so far the FDA has approved for interscalene initially for infiltration only, and later has come for a tab block as well as interscalene plane block. The main problem is availability, sir, and again cost. We go through the cost, it's almost 200 times of bupivacaine. So if we take a 20 ml of racemic bupivacaine, it's almost 60 to 70 rupees.
Yeah.
If we go for that, it's almost 12,000 rupees.
Just for completion sake, I raise this. Yeah. Thank you. Thank you, Madan.
Thank you, sir. Thank you.
Thank you.
Thank you, sir. Sorry for late joining. Due to I have COVID ICU duty, that's why I joined in late. And thank you, Dr. Kameswara sir and Dr. Chakra sir and all the senior leaders of ISA National. And one more thanks to Dr. Balavenkat sir. He's continuously sparing the most eminent faculty speakers to our ISA webinars, including Senthil Kumar sir. It's a very beautiful lecture, and Dr. Madan Mohan sir. Hello. Any questions are there, sir? Hello. Any questions are there? Shall we closing the session, sir?
Chitra, do you like to say something?
Sir, please, sir. Chitra, sir.
Please, sir.
No question, no, nothing. No question.
And if no questions, shall I close the session, sir, by saying the word of thanks?
Okay, okay.
And thank you very much, sir. Once again, thank you to Dr. Senthil Kumar sir and Madan Mohan sir, and Professor Dr. Suryasri madam, and Professor Dr. Venugopal sir, and Dr. Chaitanya sir from Bajal country. And thank you all the ASA leaders and ISAP leaders, especially Dr. Venugopal. He had some work, that's why he left the session. And thank you all. I'm
Thank
closing.
you.
Thank you all.
Thank you.
Yeah.
Thank you.
Thank
Thank
you.
you, sir. Thank you.
Opportunity. Thank you.